Hello, everyone. It's a pleasure to be here with you all. My name is Michael Broby, and I'm the ISSUP National Chapter Regional Coordinator for Africa. We're pleased that we can have another webinar from our lovely colleagues in Nigeria, ISSUP Nigeria. This is a webinar series they've been holding for the past few months, and this is the 7th in the series. So we're so pleased that we get to have an excellent webinar today. Our moderator for the webinar will be Martin, my colleague in Nigeria, and he's the president of ISSUP Nigeria, and he will be moderating the webinar for us today. So I'd like to now hand over the time to Martin, who will also introduce our speaker for the webinar today. Thank you.
Thank you, Michael. Hello, everyone. Welcome to another section of ISSUP Nigerian Chapter bi-monthly webinar tagged ISSUP Knowledge Update Series. This is the 7th session, and we are excited to have you with us. Today, we shall be looking at another very important topic, which is opioid use disorders, presentations, and management. And you will agree with me that this topic is coming at the right time, considering the global trend in opioid use and development of disorders. So to lead us into this discussion is Dr. Dauda Sulyman. And to join in moderating this session is Michael, who just introduced himself. Michael is the ISSUP Africa Regional Chapter, National Chapter Coordinator. You're welcome once again, Michael. Dr. Bawo James, incidentally, is not able to join us in today's session due to some commitments. As usual, I will start by introducing the speaker for the day. Dr. Sulyman obtained his MBBS from the University of Ilorin in the year 2000. He started his residency training in psychiatry at the Federal Neuropsychiatric Hospital, Enugu, Nigeria in 2004, before moving on to the University of Ilorin Teaching Hospital, Ilorin in the year 2006 to continue his training. He became a fellow of the National Postgraduate Medical College of Nigeria in 2010. He was appointed as a consultant psychiatrist at the Abubakar Tafawa Balewa University Teaching Hospital, Bauchi in 2012, where he was the head of the Department of Psychiatry for 9 years. He is currently a chief consultant psychiatrist at the Drug Abuse Treatment, Education, Rehabilitation Unit of the Department of Behavioural Sciences, University of Ilorin Teaching Hospital, Kwara State, Nigeria. The speaker is a master trainer in treatment Volume C package and has organized many training sessions on treatment at the Abubakar Tafawa Balewa University Teaching Hospital. He is also a master trainer in the mental health gap program in Nigeria. He is a participant in the Drug HelpNet, an emergency response program of the UNODC in Nigeria. He is a member of many technical committees, such as Association of Psychiatrists in Nigeria, Suicide Prevention Response, the Suicide Research and Prevention Initiative, and he has many publications to his credit on drug use problems in both local and international journals. Dr. Sulyman is the Northeast Coordinator and a member of the Executive Council of ISSUP Nigeria. So before I hand over to the speaker, please be reminded that you're free to send your questions as the speaker will be making this presentation. Send your questions using the chat box as I invite Dr. Sulyman to take it up from here. You're welcome.
Okay, thank you. Thank you, Martin, for that introduction. Like you said, this afternoon, we are having another section of the ISSUP Nigerian Knowledge Update series. Today is 7th in the series, and the topic today is opioid use disorders, presentations, and management. Like he rightly said, there is need to talk about opioid use disorders because of the global problem arising from the epidemic use of opioid. Taking this topic, I'm going to be talking on the following outline. I'll talk about the introduction, then talk briefly about the classes of opioid. Opioid use disorder is epidemiology, risk factor for use of opioid, before now telling us about how this disorder presents to clinicians. We talk briefly about the complications of opioid use disorders, management, and recommendation. By way of introduction, opioid can be defined as substance which could be natural or synthetic substance that interact with opioid receptors in the body. There are several types of opioid receptors in the body. Examples are the three main receptors that are listed above: mu, kappa, and delta. These receptors are present in the nerve end, in the central nervous system, as well as peripheral nervous system. This opioid, primarily, they are used as for their analgesic property. However, at higher doses, opioid can also cause euphoric events in people that uses them, and at a very high dose can lead to systemic central nervous system depressants in individuals. Opioid, because they interact with these opioid receptor cells, they have this high propensity to give positive feedback to people that are using them, thereby leading to continuous use of this opioid, despite the negative consequences from opioid use. We have classes of opioid. We have naturally occurring opioid, also known as opiates. Example of such are morphine and codeine, while we have synthetic and semi-synthetic opioid. Example of semi-synthetic opioid are fentanyl, tramadol, methadone, pentazocine. Heroin is also an example of semi-synthetic opioid, which is derived directly from morphine. We have some of these opioids are illicit drug, while others are prescription drug. That is, they are drug being prescribed mainly for pain management. Doctors and other healthcare workers prescribe opioid for pain relief, and is very effective in the management of acute pain. However, if somebody is hooked for a long time or been on opioid for a long time, it can lead to disorder. So what we know, what we now mean by opioid use disorder. According to DSM-5, say that opioid use disorders is a problematic pattern of opioid use that causes significant impairment and or distress. So in any case where there is use of opioid, and this is leading or causing significant impairment and distress to the user, that means the individual is having opioid use disorder. Previously, these disorders are classified as opioid abuse, intoxications, withdrawal syndrome, or opioid dependence in DSM-4. But presently, all of them are classified together as opioid use disorder. Generally, we know that as like other substance use disorders, opioid use disorder is also a chronic illness that is relapsing in nature. That means someone with opioid use disorder, if not treated, may be on opioid for the rest of their life. Epidemiology of opioid use disorder. From the statistics available, we know that more than 16 million people worldwide are using opioid, out of which about 2.1 million of them are in the United States alone. Also, over 120,000 deaths occur worldwide annually because of the opioid use. Another thing that needs to be emphasized here is that most patients are on chronic opioid therapy for one condition or disorder. About 50% of them end up having opioid use disorder. Also, men are more likely to use opioid generally. However, women are more likely to use prescribed opioid than men. The interpretation of this is that men are more likely to use illicit opioid than prescribed opioid. Deaths from opioid, like we said, is about 120,000 deaths annually worldwide. But we have some of these people that are affected majorly are the older people. Coming back to Nigeria, from the study conducted by UNOCD in 2018, when they are doing the survey of substance use in Nigeria, about 0.1 to 0.2% of the populace are using heroin, which is a form of opioid. And about 4.5 to 4.7 to 5.1% of the populace aged between 15 to 64 years are using opioid, prescribed opioid generally. Commonly available opioid in Nigeria are codeine, tramadol, pentazocine, and morphine. And among people that are using opioid generally, about 15% of them are using injectable form of opioid. Women also are more likely to use injection than men in the study I stated above. What are the routes of the administration of opioid generally? We have different routes by which people that are using opioids use these substances. The commonest ones are intravenous route. This produces high bioavailability to the patient, and those patients can see the effects quicker than other forms of opioid use. However, this is also associated with great danger and other complications because of the route of administration. Another route of administration is intramuscular route, which can also have some complication of intravenous use. Intranasal inhalation is also a very common method of using opioid. And the advantage of this to people that are using illicit opioid is that it requires minimal equipment, and the rapidity of producing euphoric effect is higher in people that are snuffing or having intranasal inhalation of opioid. Opioid can also be smoked, in which they call it chasing the dragon. These are the various forms of opioid and method of use in them. Now, let's talk about the risk factors for opioid use disorders. Genetic factor has been found to be one major factor for opioid use disorder. Children or offspring of those people that use opioid have higher chance of using opioid themselves. Also, availability of drug in particular society also exposes people to use of opioid. So also history of other substance use in the past is also a risk factor for use of opioid. Younger age is also said to be a factor because at this age, they want to experiment with drug and they can easily get in contact with opioid. Other factors are presence of painful conditions. People that are maybe they have accidents with painful conditions, people having terminal illnesses, people having some other conditions are very people like sickle cell anemic patients. These patients are also at risk of having opioid use disorders. Also, history of mental disorders, especially depression and anxiety disorder, has been found to be associated with use of opioid use disorder. So also is family history of addiction or substance use in the family. Other factors are severe pressure at home, previous criminal activities, and stressful life or family situations. All these have been found to predispose an individual to using opioid more than general populace. Now, talking about the opioid use disorder generally, at the beginning of this webinar, I talk about the fact that initially there are some conditions that are grouped together now and called opioid use disorder. Part of them are intoxication, withdrawal syndrome, dependence, and others. So now I want to take all these disorders one after the other, and we'll talk about the symptoms you can see in individual presenting to you with these disorders. The first one is intoxication. If an individual uses a very high dose of opioid, they can come down with intoxication. And the symptoms of opioid intoxications are slurred speech, the pupils might be constricted, what is known as pinpoint pupils. There may be decreased perception of pain, there's euphoric, and there is altered in the level of consciousness in the individual. There might be constipation, nausea, and hypotension. These are the symptoms common among people presenting with intoxications. Then patient can also present with withdrawal syndrome. And generally, these are the symptoms of withdrawal symptoms in people using opioid. They may have generalized body pain, as well with chills, cramps. Some of them will present with diarrhea. The pupil in their case now will be dilated as against the pinpoint pupil in somebody with intoxication. Some of them may also present with restlessness, anxiety symptoms. They may have nausea, vomiting, and excessive sneezing. They'll be agitated and they'll be having trouble sleeping. Running nose is also common among them, and some of them may be sweating profusely, they'll be yawning, and there will be tachycardia. Sometimes they have increased blood pressure, and such individual will be craving for the opioid during the time they are having withdrawal syndrome. The withdrawal phase of opioid can be divided into two. We have the initial phase with some symptoms, then we have later phase. When we are talking about the initial phase, we are talking about the first 24 hours of presentation, or the first 24 hours after the last use of opioid. And at this stage, patients may present to you with excessive sweating. They may complain about pain or generalized muscle ache. The patient will be restless and there will be insomnia in such patients. Some of them may have running nose and tears in the eyes. While those that are presenting after 24 hours, they may complain about abdominal cramp. Some of them may present with diarrhea, vomiting, rapid heartbeat, high blood pressure, and like we said, there will be dilated pupils in them. So these are the withdrawal symptoms of opioid use disorder. Then another symptom that is common to them is dependence. If somebody has been taking opioid for a long time, there is tendency to depend on the opioid. And if any three of these symptoms I'm going to highlight is present in the last 12 months of somebody using opioid, that means the individual is dependent on the opioid. The first among the list is taking larger amounts of opioid for a longer period of time than intended. This individual may plan to use the drug for a very short time, or plan to use a certain amount of opioid at a particular time, but they end up using larger quantity and longer time than they plan. So this is one symptom that will show you that the individual is having opioid use disorder. Another one is that there will be persistent desire to cut down the drug, or there are unsuccessful efforts to reduce or to control the use of opioid. Another symptom is spending a great deal of time obtaining or using the opioid, or recovering from the effects of the opioid. There will be craving or strong desire to use the drug. There will be problem fulfilling obligation at work, at school, and home. The individual will also continue using the opioid despite the fact that he knows there is a problem, and such as social problem or interpersonal problem. Despite all these things, the individual will continue using the substance. So if these symptoms are present, one should look out for opioid use disorder. Other symptoms are using opioid in physically hazardous situation. Then generally there will be development of tolerance. In this case, the individual will need a higher quantity of substance to have the same previous effect he used to have while using the substance. So there will be continuous increase in the dosage or the quantity of opioid the individual is also using. And if there is any attempt to reduce the quantity the individual is taking or to stop the use of opioid, there will be withdrawal symptoms. Some of those symptoms I've highlighted above. So if any individual, any patient presents with 3 or more than 3 or more of these, the highlighted symptoms, we say that the individual is having dependency syndrome. Patients can also present with overdose of opioid. This is very common when somebody is undergoing treatment and has abstained from opioid for some time. So when they go back, instead of starting with lower quantity, because they've developed tolerance in the past, they believe that they can now use that higher quantity they are using before at this present time. So they present with overdose, and these are the symptoms of opioid overdose that individual can present with. Patients may present to you with pinpoint pupils, the heart rate will decrease, body temperature will reduce, there will be reduced breathing, the consciousness will be altered, there will be loss of coordination, and there may be vomiting, constipation, shaking, sweating, and patient will go into shock. And if this is not quickly addressed, it can lead to death of the individual. How do people with opioid use disorder present? Now we talk about the symptoms, but most time patients will not come to you that it's not likely that they present to you that I'm having these particular symptoms or I'm having opioid use disorder. Only a few patients will come that way because many of them are secretive about their use of substance, and they know that sometimes the society may not support the use of substance, so they may not readily come out to present to you. But some of them will present with other disorder or other conditions, and as a clinician, you have to have high index of suspicion to discover that there is underlying problem in these people. Such patients may present with depression to you, and some of them may be using opioids as a means of treating themselves because of depression, or depression may be a comorbid condition in them. Others may present with anxiety attack, irritability. Some of them will present with lowered level of motivation. There may be poor decision making in them. Some of them may have financial problem. This is also very common because the amount of money they are spending on the substance use habits is very high. So they may have problems sustaining the habits and they may run into financial problems. Some of them may sell their property and some of them may engage in some criminal activity in order to get money to sustain the habits. Some people may be spending less time with their family. Like I said, some of them may go into criminal activity like stealing, shoplifting, and others. Some people may also engage in prostitution in order to get money to support this habit. The patient may also present with poor attention to self-care, physical appearance, and personal hygiene. If patient presents with these conditions, one needs to take a very good history, especially drug history, to know that the individual is not on drug. And if it's positive that such individual is using drug, it needs to be addressed quickly. Then talk about the complication of opioid use. These complications are majorly for those who inject opioid. And because of the route of admission, there may be problem with their veins, they may develop abscess, there may be septicemia, there may be thrombophlebitis, they can have endocarditis, and sometimes you have cases where such individual will inject, instead of injecting to the vein, there may be arterial injection, and there may be very ischemia in such patients. What about pregnant women, they are using opioid. Patients, such individuals may also present with the following complication. There may be maternal death due to overdose. Then we also have poor fetal growth in such individual. There may be preterm delivery among them, and sometimes you have stillbirth. It may also cause specific birth defects, and also patient can give birth to a baby with neonatal abstinence syndrome. In neonatal abstinence syndrome, basically what happens is that the baby in utero is getting regular supply of opioid from the mother, but after delivery, there is cessation of this opioid to the baby, and within few hours after birth, the baby will start developing withdrawal symptoms, and this is known as neonatal abstinence syndrome. How do we manage cases of opioid use disorder? Because we know that is a problem, and if nothing is done, it's going to affect the individual, it's going to affect the community, it's going to affect the world at large. The first thing we need to do is to take a very good history from the patient and the significant orders in the life of the patient. Like we said, many of them may be ashamed of the use of substance, many of them are secretive, and some of them may not want to disclose the use of the substance. So one need to take detailed and patiently follow some clue in the history of the individual and ask people around the individual to know whether this individual is using opioid or not. Also, you have to do a full physical examination, and during the physical examination, you need to look for some clue in the individual, especially those that are injecting drug. You look for signs of needle tract in them, and some of them may even have very serious skin ulcer in them. So all this will point to the use of opioid in such individual. Also, like we said, some of them may present with anxiety, depression, and other psychiatric conditions. So a full mental state examination is very important in them. Then we also rule out some other impending problem like suicide, because it's known that some of the certain proportion of people who are using opioid eventually commit suicide. So when you are assessing the mental state of the individual or the patient, you have to make sure that the individual is not suicidal at the time of the examination. The important test one need to do for people using opioids is that you do toxicology tests. They can be done using urine or blood to know the particular type of opioid individual is taking. Also, for those who are using injectable form of opioid, is very important to screen such individual for hepatitis A, B, and others. Also, we need to screen for HIV/AIDS disease. Also, liver function tests and other tests are very important. So, having done this, and you made your diagnosis of opioid use disorder. So, what is the next thing to do? The first thing is that when you are managing a case, we need to individualize that particular patient, and it's not that one treatment fits all for all cases. The patient, some patients may benefit from outpatient counseling, while others may require intensive inpatient treatment. So some may do better on short treatment, while others will require long-term therapeutic community approach. So also there are some medications that are useful and they may be found to be very effective in the management of opioid use disorder, especially during the withdrawal phase and the maintenance phase. These drugs are known as medication for opioid use disorder or medication-assisted therapy. The way this drug work is that they work by reducing withdrawal symptoms, and also they reduce the craving for opioid in those that are using opioid. Individuals that are using medication for opioid use disorders, eventually stop or decrease the use of their injectable form of opioid use. And this will go a long way in reducing the rate of contracting intravenously acquired diseases. Researchers have also shown that opioid receptor agonists like methadone, partial agonists like buprenorphine, and opioid antagonists can support recovery. These are examples of medication-assisted therapy that can be used in the management of opioid use disorder. So now I'll take some of the medication individually now. First one is methadone. Methadone works primarily to prevent withdrawal symptoms because it's an agonist of opioid. It replaces the opioid at the receptor site and prevents the withdrawal symptoms that patient may experience if the opioid has stopped abruptly. However, this drug does not have the euphoric effects commonly seen with other form of opioid, and so that's why it's being used at the withdrawal phase of the treatment. Also, methadone has been found to be useful as maintenance dose because it's not sedative and it's medically safe. After the detoxification of the individual, the maintenance phase of the opioid maintenance treatment begins about 6 weeks after the initial therapy, and the length of use varies according to the patient. Buprenorphine is a partial agonist of opioid receptors, and like I said, it's also used at the detoxification stage of the management of opioid use disorder. What this drug does is that it binds competitively to the opioid receptors, thereby preventing withdrawal symptoms in them because it has agonist property at those receptors. Meanwhile, also diminishes the craving for other form of opioid substances in them. So after using this drug for detoxification, it can also be used for maintenance phase. So, but the caveat in the use of this drug is that the drug has to be taken regularly and daily, and the patient has to present to the doctor office to get the supply, because you don't want to prescribe too much of them to the patient so that they will eventually abuse this substance too. Also, we have nitrazone, which is an agonist of opioid. What this drug is mainly for maintenance phase of the treatment after the detoxification level. It's not advisable to use this drug at the detoxification level because it will bind to the receptor site and it will precipitate serious withdrawal symptoms. So after the patient has been taken through the detoxification level and there is no longer, the patient is not having any opioid in the system by testing the urine or the blood of the individual, that's when this drug can now be instituted so that this drug will reduce the craving for the medication for the opioid. And even the individual is taking the opioid after this drug is used, the opioid use will not be able to bind to the opioid receptor, and such patient may not have the benefits or the euphoric effects expected from the opioid again. Dihydrocodeine is an alternative to use of methadone, and buprenorphine is also an opioid agonist that also binds to the opioid receptor. Because also available in oral form, can be used as detoxification at the detoxification level stage of the management. Thereby, it's also like drug used in the detoxification level is bound to the opioid receptor, preventing serious withdrawal effects because they also have some inherent opioid property. However, there is little craving after their use, so thereby the chance of addiction then, because this will be done under supervision, the chance of addiction is lower than somebody who is just using the opioid continuously without any supervision. Ranulazole is an opioid antagonist and has been found to be life-saving medication, especially for people who are using high dose of opioid. In some countries, they advise that people who are using opioid should be moving around with pre-filled auto-injection devices, so that whenever they have an overdose of the medication, people around can give them this naloxone injection before other help to arrive. So this has been found to have saved life on several occasions. Other medications that can be used during the time of detoxifications are clonidine, which has been found to decrease anxiety, which are associated with opioid use disorder. Then, if the patient is having insomnia, benzodiazepine can be used to take care of this problem. Diarrhea, vomiting, and nausea can also be managed with use of loperamide. While pain, because some of them during the withdrawal phase or when they present to me, they may present with generalized body pain. We try as much as possible to manage the pain with non-steroidal anti-inflammatory agents. It's important to state here that despite compelling evidence that medication used in the management of opioid use disorder is effective, these medications remain underutilized because of several factors. One major thing here is that some people believe that using one form of opioid to treat opioid use disorder is just like substituting one dependence with another dependence. However, National Institute of Drug Abuse stated that using medication for opioid use disorder is not sufficient of opioid use disorder because of advantages and benefits one can derive from the use of this drug. One of which is that it reduces the problem of illicit drug use, it reduces the problem of injection or injectable opioid, and make the individual more productive in society. Other factors are the fact that people that are using opioid may need to be having daily dose of medication, and probably from doctor's office, they have to present to the treatment center on daily basis to get this drug, or on few days apart. So this may become a problem in some of them. However, presently there are some drugs which are available in depot injection that can be used for some days, and these have been found to also be useful to take care of the problem of presenting daily for injection. We have extended release naltrexone, which can be given every 28 days, and we have once monthly buprenorphine injection, which is also being approved to be used. We talk about the drug management of opioid use disorder, but we know that we're talking about opioid use disorder. Drug management is not the only form of treatment that is available, and you have to combine drug treatment with other form of treatment. And another major component of treatment is psychotherapy or psychological treatment. The individual with opioid use disorder need to have this treatment as part of their treatment, and effective behavioral intervention need to be delivered to the individual who are by professional trained psychotherapists. Treatments typically involve cognitive behavioral approaches, such as encouraging the motivation to change. That is basically need to do motivational interviews technique to increase the motivation of the individual and to educate them about the danger of the drug they are using and how to prevent relapses in them. The psychotherapy need to be continued even after the detoxification state into the maintenance phase. Patients with opioid use disorder are also encouraged to participate in self-help programs such as Narcotics Anonymous. And it's believed that combination of education, motivation enhancement, and self-help group help patients to change the way they look at drug, the way they think at drug, and they also appreciate how this drug has affected their lives. So these are so that means if you are treating somebody with opioid use disorder, there is role for drug treatment, there is role for psychological treatment, and there is role for social support in individual. So before we round up this section, so let's talk about the prognosis of people using the opioid. Drug substance abuse or substance use disorder generally is a relapsing illness, and this is not different from those people that are using opioid. However, high risk of relapse and overdose is very common among people using opioid because after treatment or after abstinence for some period of time, if individual goes back to use of opioid and they now use the previously or the last dose of the substance they are using before, which is more likely to be very high to them because they will have lost their tolerance then. So this can lead to overdose and can lead to death. Also, medication-assisted therapy reduces the incidence of long-term opioid addiction, while decreasing illegal opioid use and decrease mortality. The cost to the society with opioid replacement is less compared to non-treatment. So, like the fear of some people that if you are using opioid medication for opioid use disorder to treat somebody who is already having opioid use disorder, is like substitution of addiction. However, if you compare the cost to the society of somebody who is using opioid and somebody who is on treatment, you know that the cost is far higher in people who are using substance because they be involved in criminality and some other vices in the society. Also, methadone treatment for opioid use disorder is associated with a 50% reduction in all-cause mortality, as well as 50% reduction in incidence of hepatitis B and hepatitis C. Over 90% of patients who go through opioid withdrawal phase without medication-assisted treatment relapses within 1 month. So, because some of them, because of the craving, they tend to relapse. But if you place them on medication for opioid use disorder, this reduces craving and the risk of relapse is less among those who are on medication than those who are not on medication. So, what are the recommendations here? Since we know that more than 50% of people who are chronic users are on chronic use for opioid treatment for other conditions eventually have opioid use disorder. So there should be responsible prescription of opioid analgesic in the management of chronic pain. We should try to explain other methods of pain management instead of using opioid only for the management of pain. The medication for opioid use disorder should be made available in some designated centers. So especially the low resource countries like ours, where many centers don't have this medication for the treatment of opioid disorder. More researches need to be done on opioid use disorder so that as to know which other medication can be used in the treatment of opioid use disorder. Then there should be effective regulation of opioid use disorder, and there should be education and enlightenment of the populace on the use of opioid and the dangers there with the opioid use, like the one ISSUP Nigeria is currently doing. There should also be training and retraining of professionals in the management of substance use disorder. In conclusion, I say that opioid use disorder is a chronic and relapsing disease due to use of opioid. And majority of the users start from prescription opioid. It has devastating effects on the individual, on the family, and the society. It is, however, manageable, and with use of some medication that can assist in the management and psychosocial support to prevent relapses. Some of the main medication for the management of opioid use disorder are not available in the country, hence there is need to appeal to the relevant government agency that regulate the availability of these drugs so that people that need them will get access to them. They also need for training and retraining of professionals in the field of prevention and treatment of opioid use disorder. Thank you. These are my references.
Thank you so much, Dauda, for this excellent presentation. Participants, you will agree with me that the presentation was very informative with very important recommendations. We have a couple of questions for Dauda. So, Michael, please take up the questions.
Thank you, Martin. Yeah, we've got a few questions to present to you, Dr. Dauda. So the first question I have here is from Moses. It says, in the first 24 hours of the withdrawal syndrome, how best can it be managed for the person who's in transition? So the person who's going through having severe withdrawal symptoms, how best can that person be managed?
Okay. Like I said, that in the first 24 hours, there are some symptoms that can be present in individuals. And we need to individualize the type of treatment we are going to give the individual depending on the symptoms the individual presents with. Some of them we said that may present with generalized body pain, in which we may need to use some pain relief medication. Then restlessness can be taken care of with some drug like benzodiazepine. However, the use of where the methadone and other medication of opioid use disorder is available, like methadone and buprenorphine is available, one can use this medication. At least this one will slow down the withdrawal symptoms, and you can now gradually taper down this medication over time. So that is the approach. So you individualize the individual, you can treat the symptoms. You can treat the individual based on symptoms in which they present. If you don't have medication to use for all these the agonists and partial agonists for the opioid available, then you take symptoms by symptoms and you treat them. So that's the approach one can use in such individual. Sometimes some of them may even need fluid replacement in some them, because if you have excessive vomiting or diarrhea, there may be need for you to give fluid to replace the one that the individual is losing. So this approach that you can use. Thank you
very much. Okay. Thank you very much, Doctor. I'll just move on to the next question. It says, if someone
Michael.
Yeah.
Okay, sorry, before you move to the next question, just to add that when we say particular medication can be used to manage such conditions, it is not that one is encouraging self-medication or self-prescription. It is that we, of course, most of the participants, I want to believe that most of the participants are professionals. It is that the physicians can prescribe such medications, not necessarily that one can go and get these medications to address the disorders. Thank you.
Thank you very much, Martin, for mentioning that. Of course, with these drugs, you need to seek professional help for that approval rather than be medicating yourself. Thank you very much for mentioning that, Martin. So the next question I have here, I think the one before, you've touched on it already, but this one says, what is the mechanism of heavy sweating in opioid withdrawal symptoms? But I think you've already touched on that already, Doctor. Do you wish to add something to that one?
So generally, when you're talking about the withdrawal symptoms, like the analogy we give is that if somebody is withdrawing, it's like open tap syndrome. Individual will be losing most of the body fluid, and it can come in form of sweating, vomiting, diarrhea, running nose, and tearing. So it's because of So those are the presentations. So it's part of the withdrawal symptoms in the individual.
Okay, thank you.
Sorry, Michael.
About Martin?
Yeah, if I may add, just like the presenter said, most of the side effects, or generally the side effects of opioid use is it includes constipation, and as we also know, it's a central nervous system depressant, and the withdrawal effect is usually the opposite of the side effect of opioids. So being the central nervous system depressant, you also will agree with me that sweating is part of anxiety. So you are now looking at opposite of central nervous system depressant to now anxiety, which of course is presented in the form of heavy sweating. That is just an addition. Thank you.
Thank you very much, Martin. I'll move on to the next question I have here. It says, most of us in the social sciences are not conversant with these terminologies. How do we get this scientific knowledge to assist us in psychotherapy or other preventative measures? And so that's the question there for you, Doctor.
Can you please come again?
Okay, it says here, most of us in the social sciences are not conversant with these terminologies. So the terminologies you've been describing in your presentation. It says, how do we get this scientific knowledge to assist us in psychotherapy or other preventative measures?
Okay. What I can say is that from time to time, there are organizations that organize seminars, workshops, and training on some of these disorders. And if one to acquaint himself with knowledge about this terminology, one can enroll in such program. There are online programs you can do and get, because you know that social scientists can also be useful in the management of drug disorders. But some of this terminology cannot just be broken down into layman terminology. So you have to acquaint yourself with the knowledge by enrolling in some courses or some workshops where one can be taught about these terminologies.
Thank you very much. Martin, is there anything you want to add to that? Okay. From my side, what I want to add is that you'll be able to access and gain a lot of knowledge within the field by also visiting our ISSUP website and also engaging with the ISSUP Nigeria chapter, because we have a lot of experts who have that knowledge on the ground in Nigeria that you can reach out to, with Martin being the president can also help to facilitate that. And then also on our website, which is www.issup.net, where you can also gain that knowledge once you register and become a member, and also a member of ISSUP Nigeria. So if you have questions or you want access to that knowledge, you can also gain that online on our website. Okay. So the next question I have here, questions are flooding in. We're getting a lot of questions now. It says here, if someone wants to discontinue methadone or other opioids, in this case, what medicine do you recommend for the deintoxication? So that's the question.
If you want to stop the use of methadone.
Yeah, so
like
methadone.
Okay, methadone is a drug used in treatment of opioid disorders, like I've said during the presentation. And if after using the methadone for some time, the teaching is that you have to stop this methadone also. But normally, you don't use another drug to stop that. What we talk about, tapping down the dosage. You systematically reduce the dose of the methadone you are giving over time, so that there won't be serious withdrawal symptoms and the individual will be able to cope until you are able to stop the drug completely. The advantage of methadone is that it has a long half-life than most of the other available opioids that have addictive properties. So it will be easier to space it out and eventually stop it than those opioids with a very short half-life that may be very difficult to stop or use. So while treating the methadone abuse or dependence, one may need to taper it down over time and eventually stop it. Though there are cases where some individuals may have it difficult to eventually stop methadone. They may need to be on it for a long time, but with psychosocial support, education, and trying to stop it, eventually one may be able to stop it.
Okay, thank you very much. Martin, is there anything you want to add to that?
Not anything in particular, except to draw attention to colleagues or participants that the link to some of this information is there on the chat box. You can just click on it and access where you can also get some of this information. Thank you.
Okay, thank you, Martin. And we are getting a lot of questions come through, but I think we've got time for one more, and this is a really good question. It starts off with this. It says, thank you for this presentation. May I know if all the medications discussed are available in Nigeria? Who pays for them? Finally, when do you decide to start a patient on methadone and these opioid drugs? So that's the question, Doctor.
Okay, thank you very much for that question. Like I said during the course of the presentation, one of the problems we're having in the low resource centers or country in which Nigeria is one of is non-availability of these medications. So this kind of methadone is not available in most centers. I'm not even aware of any center where it's being used presently. Though naturally we are getting it in my center in Ilorin. But like I said, the second line drug for the management is dihydrocodeine, which is available in Nigeria. So we make use of that particular drug in my center. And on the question of who pays for the treatment, ideally supposed to be if individual is enrolled in NHIS, it can be done, but most patients pay out of pocket and they pay for their treatment most time. That's the truth about the management here. Most of the patients, they pay out of pocket for their treatment. Okay.
Okay, thank you. Thank you for that. Martin, anything you want to add on that?
No, Michael.
Okay, that's great. Okay, it seems we've got a couple of minutes and I think we can have one more question. Bear with me. We have a lot of questions coming in. It says here, do you encourage opioid substitution therapy for chronic opioid user? And that's a question that's come through.
Okay. The substitution, like I said, the National Institute for Drug Abuse have said that using an antagonist of opioid or partial agonist in the treatment of opioid disorder is not substitution of one opioid for another opioid per se, but is the form of treatment that, if you look at the cost effectiveness of treating with this drug and not treating with them, it's better to use them. From one of the studies I highlighted in the course of the presentation, it says that about 90% of patients that underwent treatment, detoxification treatment, without using assisted medication assisted therapy, 90% of them relapse within 1 month. We know that this is very high and is not acceptable if you know what you are doing. So using this medication, we assist you to take the individual off illicit medication. We also help them in reducing the rates of use of intravenous route for the medication, which can also lead to other problems like acquiring. Can you get me?
Yes, you can hear.
So using this medication. So if you look at the advantage of using medication-assisted therapy, it far outweighs the problem of not using it. So that's why I also support their use, though by specialists who are trained specifically in the treatment or in the management of opioid use disorder, not by anybody in the public.
Okay, thank you very much. Anything you wish to add to that, Martin?
No, except that we are gradually out of time. It looks like we won't be able to take any more questions.
Yes, we had a good flurry of questions at the end there, and unfortunately, because of time, we're not able to go through all of it. But what I want to say is, once again, thank you very much, Dr. Dauda Sulyman. Thank you for the presentation. It was excellent. We learned so much from you, and I hope all those that turned in for the webinar also gained a lot of knowledge and insights. Once again, if you want to learn more about the good work being done by ISSUP Nigeria, you can go on their ISSUP website, www.issup.net, and you can go on the national chapters, and ISSUP Nigeria is there, and you can follow along with the good work that you're doing, and also be able to register and become a member and gain access to all that information. So once again, I want to say a big thank you to the doctor for his excellent presentation, and we hope to have all of you join us once again for another webinar in the next few weeks when they take place. So thank you very much.
Thank you.
Thanks.
Once again, thank you, Michael, for co-moderating this session. You did an excellent job. And so, Dr. Dauda Sulyman, I must commend you for an excellent presentation. I want to believe that the participants have gained so much from this. What we'll continue to do is to share the evidence, because evidence is what will guide, our activities and eventually change perception. Of course, there are barriers to the use of methadone, for example, or other substitution therapy. But what is important is that once we have the evidence, we'll continue to push it so that people begin to realize the benefit or the importance why it has to be, why we have to use medication-assisted treatment, or at least for the treatment of people with opioid use disorders and so on. So it is on this note, once again, on behalf of the Board of Trustees of ISSUP Nigerian Chapter, the Executive Council and members of ISSUP Nigerian Chapter, extend appreciation to you and say thank you for joining us as we look forward to another beautiful session or very informative session again in September. Please do join us, and we cannot thank ISSUP Global enough for all the support. So at this point, I say thank you once again, and bye for now. Thank you.
Thanks. Bye-bye.
Bye.